Hey guys, it's Scott from the clinical department, and in this video I wanted to talk about titrating your PEEP a little bit. On our ventilator, once we've got everything set up, we've put our tubing on, we've put our filter on, we've got our patient intubated, we've found our tidal volume, we've got a PIP pressure that looks reasonable, somewhere between, maybe 15 to 25 or 30, depending on what causes the chest to rise. We've got auscultated lung sounds. We know we've got good recruitment. We're getting air blown down into even the bases, and maybe we've got our respiratory rate set. We started at whatever we calculated a respiratory rate to be, 12 or 14 or 16, and we're got a good CO2 level that's somewhere around 40, and we'll talk about those in other videos why we would change different respiratory rates. But everything's all set. FiO2 is up. Let's say our patient is still hypoxic. This is the time when we need to be thinking about PEEP. Some of the things that make me think about manipulating the PEEP and changing those settings, as I said, is an oxygenation problem. PEEP is oxygenation for your patient. And anytime I consider a patient that's not oxygenating well or has a pathology that is related to any kind of fluid, so with that I mean a pneumonia patient, CHF, and you're drowning, and once in a while, even your chronic, your long-term overdoses that have been hypoventilating for a while, those folks tend to seep a little bit of pulmonary edema as well. And some increased PEEP might do them a little bit of good. So, when we come to thinking about PEEP, generally 3 to 5 is what we consider physiologic. So that's very therapeutic. If there's not a lot of fluid in the lungs and we're getting good oxygenation, we don't have to change that. But in cases where there's a fluid pathology and we can use, hypertensive CHF, that's a really good case to consider using some PEEP on. We may have to turn it up a little bit. Say we've intubated. We're talking about intubated patients. We'll do another video on BiPAP and talk about the therapies there. But on intubated patients, sometimes if my SATs are low and I've already gone to 100%, I've got nowhere left to go with 100% O2. That's all I can do. Patient's still hypoxic, then I'm going to start using PEEP. Now, if you want to think of PEEP correctly, it's not a pressure that's even going to put your patient at risk for pneumothorax. If you want to consider what causes my patient to get a pneumothorax, then that's when you set your tidal volume. High tidal volumes are the things that are putting your patient's lungs at risk, not PEEP. PEEP is the end of exhalation. It's the end of exhalation so that we hold higher concentrations of oxygen in the alveoli longer so that those alveoli don't collapse, and it's also longer so that there's more time for diffusion across the barrier from the inside of the alveoli into the red blood cells and onto the hemoglobin. So using PEEP is basically a tool to increase oxygenation in an effort to ultimately bring our FiO2 down to as low as we can get it and the patient still stay oxygenated very well. So many times, I'll put the patient on AC mode and I'll have them on 100% O2 and I'll listen to their lungs and make sure everything's good as far as getting good recruitment. With recruitment, what I mean is, have I given enough tidal volume that have I gotten the entire lung fields on both sides to where they're participating in each ventilation. So I need to listen deep on the sides and listen to those bases and see if they've got air moving in and out of them. So if I need PEEP for oxygenation, then I might take that 5 centimeters of water of PEEP and turn it up to 7 and then see what results from that. Give your patient a few minutes to start changing their SATs. Sometimes it could take over a minute for the SATs to change. With increasing pulse oxes, though, sometimes they come up a little bit quicker than they go down. So I'm also, still old school, just looking at my patient. Do they look pale and hypoxic? Do they look cyanotic? That's a very good indicator that we need to start increasing things as far as PEEP, making sure we got good ventilations. Once I set my tidal volume, that's going to usually stay where it's at. So I'm going to utilize PEEP to get oxygenation. If my SATs, are still way lower than I feel like they should be, then I'm going to keep gently going up with PEEP until I get better oxygenation by holding a little bit more pressure in that exhalation phase of breathing. So if I get good oxygenation by getting my PEEP up, and when I talk about raising the PEEP, sometimes when you go from 5, you want to go to 7 and see what you get in a few minutes. If 7 doesn't work, you may want to go to 8 or 9, and maybe you're going to end up at 10. I think you're going to start reaching comfortable limits at a PEEP of 10, 12. I've used PEEPs that are higher, 14, 16, 18, but those are very rare times. The big sacrifice that you have to always consider when you're using PEEP is that when you increase PEEP, you're going to increase thoracic pressure, and it's never going to lower. The PEEP that you set is the lowest pressure that the lungs actually ever feel, because it only goes higher than that with each breath, and the tidal volume going in raises it up, and then it only comes back down to whatever you got your PEEP set at. So if I increase in a thoracic pressure, I'm going to put pressure on the superior vena cava and inferior vena cava, the blood returning to the right atrium, and you're going to start seeing some trending blood pressures that are going to start going down. Now, if that's concerning you, well, we have to talk about how low did that pressure go? And if the pressure went down into the 90s or the 80s, then I'm probably not going to do much more than just add some fluids. Adding fluids to patients that are still hypoxic and they need the PEEP, I will not take the PEEP away just because their blood pressure came down a little bit because I needed to get the PEEP up to get them oxygenated. If they're not oxygenated, everything else, it doesn't matter nearly as much. So if the pressure starts to drop, open up their fluids. Now, if you're concerned about, well, if I open up fluids and they, and they got pulmonary edema, you can't give them more pulmonary edema. If you're increasing the PEEP this much, you're going to push that fluid back across. And if their pressure is low, there's not enough pressure on the vascular side to actually push the fluid across into the alveolar space. So giving them fluids, you're just trying to fill up their vascular system to make sure that their volume is high enough that they can actually take advantage of whatever cardiac output they have and their vascular resistance and get a decent blood pressure. Do a cap refill on the ears. If you're looking, am I getting good perfusion to the head? Because the ears are supplied with blood through the external carotids. If the external carotids are getting good perfusion, then I would assume pretty safely that the internal carotids and the vertebral arteries are also providing some blood flow to the head. So just check cap refill in the ears and see what it looks like. That's how I know that that's the blood pressure I need to get my patient some perfusion. Now, I talk about blood pressure a lot. I want you to look at MAP pressures more than I do blood pressures, and I want you to try to shoot for a MAP of 60 to 65. That's kind of the bottom line for most of our medical patients. We can consider times the increased MAPs of 80 or 85 with head injury patients, but generally we're looking at 60 to 65 on a MAP pressure. So if you have to increase the PEEP for oxygenation, then give them fluids, IV. Your sick patient should have 2 IVs every time, so use one of those to give fluids. At the worst case scenario, should I really need to start giving a lot of PEEP, and I'm up at 10 or 12 or maybe 14, and before I really see some oxygenation, before it even reaches 90% at my SpO2, I may have to actually add some pressors, and I'm probably dealing with, in that case, some sort of a septicemia, hypovolemia, tachycardia. And so if I've already filled up the tank and I know I've got, maybe 500 mils to 1,000 mils in, and I'm still hypotensive, and I've got to keep the PEEP on there so that the patient stays oxygenated, it might be a time to do a low dose levofed to clamp that vascular down a little bit and keep that perfusion going to the brain, so that now that we're oxygenating with our PEEP and our good vent settings, that we also have good blood pressure to support good cerebral perfusion so the brain stays well oxygenated. So hopefully that helps a little bit with PEEP. I want you to always take advantage of it. It should probably be bare minimum at 3 in just about all of the conditions that you're going to use a ventilator on. And your goal is to increase PEEP so that you can bring the FiO2 down. We don't want to just use FiO2 to keep patients oxygenated. I like to bring the FiO2 down, 40, 60%, sometimes lower, based on what they need. But, utilize PEEP to balance those out. If you look at ARDSNet, you can see that there's a PEEP scale, and what it does is it correlates levels of oxygen, FiO2 with PEEP, and they work together. So we're going to start out with a high FiO2 and low PEEP, and then we're going to try to bring the FiO2 down as we bring the PEEP up and get them to where they're somewhat in that scale of the PEEP scale. So I encourage you to take a look at that. ARDSNet has that PEEP scale. There's a lot of resources out there now for this, but don't be afraid of PEEP. You're not going to pop anybody's head off, but you're certainly going to provide some good oxygenation for them, pre and post intubation. So it's definitely a tool we're going to take advantage of and make our patients better. So thank you.